Hi guys, my name is Andrea Beaton. I'm one of the cardiologists here at Cincinnati Children's Hospital, and I have the privilege of talking to you guys today about pediatric chest pain. We're going to do this in 20 minutes or less. So pediatric chest pain is one of the most common reasons for children to visit their primary healthcare provider or come to the emergency room. It's also the second most common reason for children to go to their pediatric cardiologist, followed only by heart murmurs. But 98% of chest pain in children is non-cardiac. So your job, and what I'm going to try to do in this presentation, is going to be to separate out chest pain that's important, that's cardiac, and chest pain where reassurance is really the best route. So we'll start with non-cardiac chest pain. There are four main causes of non-cardiac chest pain that you can triage children into based mainly on their history. History is really going to be the key when we're talking about chest pain, and you can get the right answer for your boards mainly by what they tell you in the description only. So musculoskeletal chest pain is the most common cause of chest pain in children. I'm going to give you the list here: costochondritis, tsetse syndrome, nonspecific, slipping rib, and trauma, and we'll go over those briefly on how to tell them apart. Then there's pulmonary chest pain. I won't read the list to you today, but we'll go over them. Gastrointestinal, and then miscellaneous, things like sickle cell, vaso-occlusive crises, and others that we'll go over. So musculoskeletal chest pain is going to be the most common thing that you'll see out in your general practice. It's not actually the most common thing on the boards because it's not as interesting. So there are five main categories you need to be able to find out for your pediatric board exam. The first is costochondritis. This pain is going to be unilateral, so one-sided, sharp, stabbing, and localized to a costochondral joint or several joints on exam. The important distinction here from the next one we'll talk about is there's no visible redness or swelling that you can see on the chest wall. These kids in the history are going to say it's made worse by deep breathing, the pain can last seconds to minutes, and it's reproducible chest wall tenderness. The answer to all of these on the treatment side is going to be the same, so we'll go to the next one. This is a very specific disorder called tsetse syndrome. This is a buzzword on the boards because, or a commonly asked question on the boards because there is a visible redness over the joint. So these children are going to say the same thing as costochondritis, a local inflammation, a one-sided pain that's localized to one of the costochondral joints, but on the exam you'll see that there's a bright red spot or a swelling over that joint. The history that will tip you off is usually a recent upper respiratory infection with excessive coughing. This is not commonly seen in the real world, but it likes to come up on exams because of that visible redness. The third thing we'll talk about under musculoskeletal is idiopathic chest pain. This is really the most common thing we see in the real world as well. This is sharp pain. It lasts seconds. It's mid-sternal or left-sided, and it's made worse by deep breathing or chest pressure. The reassuring finding that you'll see in these cases is that it occurs at rest. We're going to go over red flags later, but at rest is a reassuring sign when you're talking about pediatric chest pain. The next is trauma or strain. The buzzwords they like to throw in for a trauma or a strain in the muscles are little girls who participate in gymnastics or older children who participate in weightlifting. This pain is going to be reproducible with movement. And the final one is called precordial catch syndrome. The fancy name for it is Texidor's twinge. This is a sharp, sudden second pain. It lasts just for 1 or 2 seconds. And there's an unknown cause, but it's associated with poor posture. The most important thing here, other than the different causes of musculoskeletal chest pain, is that your answer is reassurance. These children do not require a cardiac consultation. You do not need to order an EKG or further testing. If their history is clear, it's reassurance, and if it's a choice, it's NSAIDs if you think the pain is lasting longer than a week, or in the case of tsetse syndrome, where you think you can reduce the inflammation in the chest wall. The next cause of non-cardiac chest pain is respiratory. This is 2 to 11% of chest pain in kids, and the most common cause is exercise-induced asthma that can cause pain even absent wheezing. These kids are likely to have a history of needing bronchodilators in the past for respiratory illnesses or young childhood asthma, and will present with a history of cough and chest pain during exercise or after exercise. In these kids, if you have a clear history of wheezing or of chest pain with exercise but asthma in the past, a trial of bronchodilators is reasonable if there are no other red flags of cardiac disease. And we'll talk about those red flags in a moment. The other important cause of respiratory is pulmonary embolism. Your trigger for pulmonary embolism to come to your mind on the exams is going to be intense chest pain and hypoxia. Exercise-induced asthma should not lead to hypoxia, and so a child presenting in respiratory distress with chest pain and low oxygen saturations, pulmonary embolism needs to come to your mind. The next cause of non-cardiac chest pain is gastrointestinal. This is about 8% of chest pain, and GERD is by far the most common, so gastroesophageal reflux disease. These children or young adolescents will describe a burning pain in the epigastric area, and they'll give you a temporal relationship to food on the exam. Here, a trial of H2 blockers or a proton pump inhibitor is reasonable, again, with a very clear history and no red flags. These children do not require further cardiac testing. Finally, there's this miscellaneous category of chest pain. Most commonly, this is going to be anxiety or conversion disorder, can be as severe as panic attacks in children. They're going to ask you about recent stressors or give you a history of recent stressors on the examination. And when physicians have done studies of chest pain in the ER, a third of children presenting to the ER with chest pain do have a history of a recent stressful event. So I think we underestimate how much anxiety contributes to chest pain in children. The other sort of random cause of chest pain that can come up on an exam setting is herpes zoster. So if you see a child with chest pain that's in a dermatomal pattern, they'll give you that buzzword usually, a striped pattern across the chest, and that's burning pain or a numbness, a paresthesia. Herpes zoster can also present as a primary cause of chest pain in children. So more interesting, at least to me as a cardiologist, we'll talk a little bit more about cardiac chest pain and what should tip you off that a cardiac workup is needed. So what causes cardiac chest pain in children? There's really only two reasons, and I often explain this to my parents who are coming in. The first is a lack of oxygen to the heart muscle or the myocardium, and the second is an inflammation in the heart muscle. So two reasons you can have lack of oxygen to the heart muscle. The first is increased myocardial demand. So you have a heart muscle disease like a cardiomyopathy, and it requires more oxygen, and you're not able to deliver that oxygen to the heart muscle tissue. And the other is decreased oxygen supply, far more common in children. This is outflow tract obstruction on the left side, so blood can't exit the heart to get to the coronary arteries. This is arrhythmia, so the heart can't pump effectively to fill the coronary arteries. Or a coronary artery abnormality. You can have congenital anomalies, such as anomalous left coronary from the pulmonary artery or the left artery coming off the wrong sinus. We'll talk about those in more detail. You can have acquired causes of coronary artery anomalies like Kawasaki's disease, arterial switch operations where we've moved the coronaries, or a heart transplant with cardiac disease. Or you can have induced coronary abnormalities like cocaine use with coronary artery vasospasm. On the other side, inflammation of the heart, we're really talking here about pericarditis and myocarditis as our main causes of inflammation and cardiac chest pain. So red flags. I put this big slide up here of red flags because this is really, again, going to be your answer. Cardiac chest pain on the exam, an examination format, has some very clear red flags that tip you off onto which direction you can go. As in most things, this is more complicated in real life, but on the exam, there are certain buzzwords you should be looking for. First, for children presenting with inflammation of the heart. We'll talk first about pericarditis. You guys are aware, most commonly this is viral. You'll have a kid presenting with fever, and the classic presentation is a sharp retrosternal chest pain that radiates to the left shoulder. This kid is going to be uncomfortable when they're supine, when they're laying down, and they're going to sit up and lean forward to relieve the pressure on the chest to create some space in the pericardium, which reduces the pain. Your buzzword here is improves with bending forward. This is the only kind of chest pain that improves when a child sits up and bends over, and they tend to do that spontaneously. You'll order an EKG and you'll see diffuse ST segment elevations, at least in the acute phase of pericarditis, and the chest x-ray may show enlarged cardiac silhouette where the fluid is creating a larger shadow on the x-ray. Your next step here, if you haven't done one, is an EKG. After that is an echocardiogram, and your treatment is going to be NSAIDs as the answer. Myocarditis can also cause nonspecific chest pain in children. Here, they're going to have to give you more information. You're going to have a gallop or hepatomegaly on exam. If you order labs, your troponin will be elevated, and the next step here is an echocardiogram. Looking at decreased filling of the coronary arteries, left ventricular outflow tract obstruction, or the blood leaving the left heart, is a common cause of structural chest pain in children. The coronary arteries fill during diastole when the heart is relaxing. And so when you have an obstruction of the left side of the heart, you can't get enough blood out to create the coronary perfusion pressure you need to supply the heart muscle with oxygen. This is a surgical problem. So if you identify a left ventricular outflow tract obstruction causing chest pain on the exam, the answer is refer the child to cardiology for surgical evaluation. Your buzzwords here are going to be a harsh systolic ejection murmur or a click, indicating a bicuspid valve. These children are going to have pain associated with exercise or exertion. Another red flag, chest pain with exercise or exertion deserves a cardiac workup. The kids will have dizziness or fatigue with exercise, and syncope with exercise can occur because you can't increase your cardiac output to maintain the output you need for exercise. So syncope with exercise is another red flag. Cardiomyopathy can also cause chest pain in children with exercise, again because of this increased need for oxygen and the inability to deliver oxygen. You can see in the picture there hypertrophic cardiomyopathy, or how thick the heart muscle is. In hypertrophic cardiomyopathy, the coronary arteries can't dive deep enough into the myocardium to adequately perfuse the heart with oxygen. So when these children exercise, they can present with pain, exercise intolerance, and fatigue. And the EKG here is your next step. Has a very high sensitivity for hypertrophic cardiomyopathy. You'll see very large R waves in the lateral leads. Coronary artery abnormalities are diverse, and diagnosing very specific ones on the exam are unlikely to come up, but you will need to know that the coronary artery is causing a problem. This can be abnormal anatomy, coronary fistulas, coronary stenosis, and it's the second most common cause of cardiac death in children. These kids can present for the very first time with sudden death. Over 50% of children with a coronary abnormality are diagnosed at the time of sudden death or at a cardiac arrest, but they also can have symptoms ahead of time. Anginal chest pain, so children who describe a squeezing or a tightness in their chest, associated pain with sweating or diaphoresis, or a child that appears ill with chest pain. Syncope, again with exercise, red flag. Any history of congenital heart disease in a child with chest pain is a red flag. That child gets a full cardiac evaluation. Here specifically, children who have transposition, Kawasaki's disease. And again, any substance abuse, in particular cocaine, which can lead to coronary artery vasospasm. So genetics can also play a factor in chest pain in children and causes of chest pain in children, and so you want to watch out for these other flags. The main ones to watch for are children with Marfan syndrome, Turner syndrome, Ehlers-Danlos syndrome, or homocystinuria. All of these children are at risk for aortic aneurysm and rupture. Again, your buzzword for aortic aneurysm and rupture is going to be the extremely severe chest pain with a tearing pain that radiates to the back. So just to go back over the buzzwords you're looking for on the exam, cardiac chest pain is exertional. It can be associated with palpitations if there's a rhythm problem. You can see sudden syncope with no prodrome, in particular with exercise. A history of cardiac disease with surgery or cardiac transplantation is important. A history of Kawasaki's disease, as these children can present late in life with coronary problems causing chest pain, and any family history of sudden death, arrhythmia, or a genetic syndrome. To go over a quick few cases of things that you might see on an exam. So a 15-year-old with tall stature and glasses presents to the ER with a tearing pain that radiates to his back. You're thinking Marfan syndrome, ruptured aortic aneurysm. You get a CT angio. Another common case scenario, a 4-year-old presents to the ER with fever and chest pain but refuses to lie down on exam. You hear distant heart sounds on auscultation. What are you thinking? You're thinking pericarditis. What is your next step? Your next step is echo, NSAIDs, plus or minus colchicine. Sorry, I'm in such trouble with that word. The next one, a 12-year-old female is come to the ER after collapsing during track practice. You hear an ejection click at the right upper sternal border. What are you thinking? Left ventricular outflow tract obstruction. What is your next step? you need a cardiac consultation or an echocardiogram to diagnose this structural cause of cardiac chest pain. The next one, a 16-year-old in your office complains of sharp left-sided chest pain that lasts 2 to 3 seconds, typically when watching TV or sitting in class. What are you thinking? You're thinking idiopathic chest pain. What do? That's reassurance. The next one, there's a lot of these. The 14-year-old complains of burning mid-sternal chest pain, and the pain typically occurs in the evening after dinner when he lays down to watch TV. What are you thinking? Gastroesophageal reflux disease. What do? This is a trial of an H2 blocker. We've got 5 more. A 12-year-old has an episode of syncope midway through his 400-meter track race for his school team. What are you thinking? Cardiac. This is hypertrophic cardiomyopathy or a coronary issue until proven otherwise. What is your next step? Your next step is cardiology consultation, EKG, and exercise restriction, whatever they give you on the exam. A 10-year-old complains of chest pain in gym class that's associated with cough and shortness of breath. What are you thinking? This is exercise-induced asthma. Your next step is a bronchodilator. A 6-year-old boy is complaining of left-sided chest pain, and he also has fever and upper respiratory tract symptoms. Exam reveals a gallop. What are you thinking? This is myocarditis. The next depends on the stability of the child, but likely on an exam you're going to be asked about an EKG, an echocardiogram, or ordering labs for a troponin. We're almost done. A 15-year-old complains of chest pain that happens only during the week, never complains of pain on the weekends, and this is associated with abdominal pain, maybe a headache, and also some fast heart rate. Here, you're thinking anxiety. This comes up a lot in exams as well. Again, your reassurance, or you're referring this child for an appropriate consultation for counseling or psychiatric evaluation. Finally, a 9-year-old complains of focal chest pain on the left side, and when you look at his chest, there's a visible redness or swelling at the second costochondral joint. Here, what are you thinking? This is Tsetse syndrome, and your next step is NSAIDs and reassurance for the family. So as you can see, most causes of cardiac chest pain can be summed up for exam purposes in a few sentences, and so you should be remembering these buzzwords and looking for them on the exam.